Good morning, everyone. I am Christina Marie and Reina, a third year nursing student, and today I'll be discussing about otosclerosis, which is a middle ear disorder. So these are the table of content of my discussion for today. It includes the background of my topic, the pathophysiology, risk factors, symptoms, diagnosis, nursing management, and treatment. Now, what is autosclerosis? According to Grossman and Porth on 2014, autosclerosis involves the stapes and is thought to result from the formation of new abnormal spongy bone, especially around the oval window, with resulting fixation of the stapes.
Otosclerosis is characterized by an abnormal growth of bone near the middle ear. Otosclerosis is the most common cause of hearing loss in young adults. If left untreated, hearing loss will worsen progressively until it results in complete deafness. The two ears may be affected, but it is very common for one ear to be intensely affected than the other. Both men and women get affected, but it is more common in women than in men. Otosclerosis is characterized by an abnormal
Now, the
growth
exact
of bone
cause
near the
of
middle ear.
autosclerosis is
Autosclerosis
not
is the most
known.
common. Autosclerosis has to do with the small bones in the middle ear, usually the one called the stapes. For hearing to occur, the stapes bone has to vibrate. However, when the bone tissue develops around the stapes in a way it shouldn't, this bone development prevents the stapes from vibrating normally in response to sound waves. In the absence of the vibration, sound can travel from the middle ear to the inner ear. This makes it harder for a hearing to occur. Otosclerosis has to do with the small.
All right, so now let's go to pathophysiology. Now, bony changes vary according to the duration of the diseases, especially in ear diseases. So, first, the normal bone is absorbed and replaced by vascular, spongy osteoid tissue and advanced with blood vessels. Then, later on, the bone becomes thicker and less vascular. Then, a new bone formation takes place at annular ligament of the oval window, fixing the stapes and leads to conductive deafness. After that, it now spread to the footplates of the stapes and affects the bony capsule of the labyrinth, which results now in sensory neural hearing loss or deafness.
Now, the following factors can raise your chances of otosclerosis. Family history. Otosclerosis usually runs in the family and may be passed down. Measles. If you had measles at any time, your risk may be higher. CDC outlines that ear infections occur in about 1 in 10 measles cases, and the consequences can for some be permanent hearing loss. The reason that measles virus is a risk factor of otosclerosis is that they might play an important role as an environmental stimulus in the etiopathogenesis of otosclerosis. Fractures to the bony tissue around your inner ear. An autoimmune disorder that can also be linked to the condition. Another one is pregnancy, and according to experts, a pregnant woman with otosclerosis is more likely to lose hearing faster than a man or a woman who isn't pregnant. Also includes white people, which are more likely to get it than people of other races. Now, the following factors can symptoms. So it includes hearing loss, which may either occur in both ears or in just one ear. And you may notice that you're unable to hear at low frequencies, such as people whispering or low pitched sounds, dizziness, ringing or hissing in your ears, and vertigo or balance problems. Symptoms. So it includes hearing loss. Diagnosis. In making a diagnosis, the physician will ask about your family health history and take a closer look at your ear and test your hearing. On otoscope examination, it usually reveals a normal tympanic membrane. Rene's test, which is another diagnostic test used when conductive hearing loss is suspected and used in patients with otosclerosis to determine if a patient might benefit from stapes surgery. So usually, a patient with autosclerosis will have a finding of bone conduction which is better than ear conduction. Another one is audiogram, which confirms conductive hearing loss or mixed loss, especially in the low frequencies. The physician may also request you to cover one ear each at a time, and this is done to check how much you hear spoken words and respond to other sounds. Sometimes, the physician may recommend a CT scan or a series of X-rays taken at different angles, which are put together to make a more detailed image of your ear. Diagnosis. In
Nursing management. So, for a patient with operated ear, it is advised that they are upside for 24 hours after occupational therapy and also to assess and monitor their vital signs in order for us nurses to identify if there are any deviations from normal range. Also, precautionary measures in ambulation is indicated as dizziness may occur. Reassure the patient that dizziness is temporary and observe for any signs and symptoms of bleeding, drainage, and nausea or vomiting. Also, don't forget to assess the vertigo of the patient in quiet, rest, sedative moods. Administer antibiotics and analgesics as prescribed to control infection and pain. Observe any signs and symptoms of nystagmus. Nystagmus is an involuntary circular movement of your eye, and any signs and symptoms of facial palsy or Bell's palsy. Medicated ribbon gauze pack is also to be removed after 5 to 7 days, and a decongestant is also administered and dilated in eustachian tube. For discharge planning, advise the patient to avoid water in ear for 2 months, loud noise, blowing nose and mouth, and open when sneezing. Also advise the patient to avoid straining, bending, heavy lifting, and infection. Strictly instruct the patient to adhere to the full course of antibiotic therapy as advised.
treatment. Treatment may not be needed until the degree of hearing loss is significant. Getting treatment can improve your quality of life drastically. So options may include medication. Now some studies have suggested that taking fluoride, calcium, and vitamin D supplements may help to slow the progression of otosclerosis. However, this treatment needs further research before it can be confirmed. Hearing aids may also help your condition and may be recommended in the early stage if you do not wish to undergo surgery. Stronger hearing aids may be required as time goes by since deafness is progressive. Surgical treatment. One of the two surgical procedures that may be performed are stapedectomy or stapedotomy. The physician may recommend a surgery called stapedectomy. Now, a stapedectomy involves removing the stape superstructure and part of the foot plate and inserting a tissue graft and a suitable prosthesis on it. In a stapedotomy, the surgeon drills a small hole into the stapes and instead of removing it, to hold a prosthesis, which I'll be showing you a quick video later. Now, these surgical operations can provide a better solution as it restores hearing. If otosclerosis is affecting both ears, your ears will be operated on one at a time. After the first one, a waiting period of 6 months is needed before the second ear can be operated on. Treatment. Treatment may not be needed until the degree of hearing.
Autosclerosis is an abnormal sponge-like bone growth often found on the footplate of the stapes. The malleus and incus can have slight movement, but the stapes cannot move, so the sound is either severely reduced or never reaches the inner ear. Stapedotomy is the procedure to fix this condition. The surgery is made via the external auditory canal. Step 1 is to delicately separate the joint between the incus and the stapes. Next, malleus incus mobility is confirmed, and the stapes immobility due to the autosclerosis of the footplate can be confirmed with gentle pressure. Notice the up and down piston movement is impossible. We need to remove the stapes superstructure. First, we divide the stapes tendon. Then we use a laser to reduce the thickness of the posterior and anterior crura. The final cuts are done using a low-speed microdrill with a 0.7mm diamond dust burr, and the remaining structure is removed with a microhook. The distance is now measured from the incus to the stapes footplate to determine prosthesis length. A fenestree, or opening, is needed through the stapes footplate. A laser is used to make a rosette pattern. Then the final opening is done with the microdrill. Next, a vein graft is placed into position. According to the measurement taken previously, the stapes prosthesis is trimmed to size. The loop is opened to break the Teflon memory, and the distal tip of the shaft is introduced over the vein into the fenestree. The loop on the opposing side is then crimped around the incus. Final positioning is carefully checked by means of a gentle bend test to make sure everything stays in place. Now the ossicular chain can transfer the sound movement all the way to the inner ear.
So that's all for today's video. Thank
Autosclerosis
you
is
so
an
much for
abnormal
listening and
sponge-like
watching.
bone growth